let's move on a little bit. So Neal, you brought up something very interesting. So pretty much though, when we talk about just looking at localized disease for a second, we talk about a little bit about it's mostly radiation, prostatectomy, the majority of which are robotically assisted. But you made mention some of these newer therapies that potentially could be focal therapy or localized therapy. Expand a little bit on that.
Well, I'm not promoting
Right.
any of these focal therapies as having enough evidence-based literature and data prospectively accomplished and or published and adequately reviewed that they're ready for prime time. That said, it's intriguing, right? I mean, if I can get a quality focal therapy that limits collateral damage to my bladder, my rectum, and my nerves of erection, and my voiding pattern, and put the disease in remission, or better yet, cure it on an outpatient basis with a minimal amount of risk of blood loss or catheterization, et cetera, and it's reasonably cost effective, well, I'm all in on that. Now, that could be an ablative technology that with heat or cold, that could be with radiation energy, it could be with an injection potentially. So I think this is all very interesting, especially if you find that subset population that's really right for focal treatment. The big challenge is making sure we know the old hackneyed expression, right patient, right treatment, right time. And we're really at this era now where there is, it's got to be cost effective. There has to be real economic utility. And you and I have done a lot of work on this. We're moving from this volume-based model to the value-based model. So in some ways, the right focal therapy, the ideal one would be something that was clinic-based, didn't require a super expensive amount of technology because the prostate's so accessible given its location. So I think that in sort of blue sky treetop view of it all, that's how I'm thinking about it. What's always concerning is a lot of companies that get into the field for their obvious reasons for promoting their technique, their technology prematurely, and we've seen a lot of that. So I would caution everyone listening to just make sure that they understand the data and rather than start embarking on things too early.
So Mike, Evan, Glenn, in your institutions, what about combinations of therapies, especially the uses of some of these newer agents that now are approved, obviously in the CRPC space? What are there many trials using them in combination, especially with radiation? Again, trying to better offer therapy for these localized tumors. Glenn, what sort of experience are you having?
Looking in two different ways for the patients, again, early in their journey, but very high risk. We do look at combining long-term, whether it's 2 to 3 years of androgen suppression along with external beam and some form of brachytherapy, whether it's seed implant or high-dose rate implant, again, maximizing the dose of radiation to the cancer cells while sparing the normal tissues. So that's been around for quite a while, and there are protocols that have been published. The data looks pretty good for patients at highest risk, so Gleason score 8, 9, 10, that if you add high-dose rate brachytherapy to the androgen suppression and the external beam, the patients do better in terms of progression-free survival. So those are the kind of things that we've been looking at when it's early in the journey, but high risk. But we're looking at adding combinations of therapy once we're dealing with castrate resistance, where it's metastatic. That I think is very exciting, and again, every week something new comes out in terms of combining different drugs. The key there is making sure that you can do that in a safe and efficacious way.
I think there's a lot of extrapolation for the high-risk patient. If they're really that high risk and you give hormones and radiation, should you add in docetaxel? Should you add in, one of these newer AR target agents? That's research in my opinion, but I think, or registry data to sort of see what is the outcome for that. The newer group that people are talking about that still present, and particularly with novel imaging for these high-risk patients, you find oligometastatic disease, and current belief is this all that it is, and if you manage that. So we've got clinical trial protocols where we're taking care of the local disease either with radiation or surgery, then hormonal therapy, chemotherapy. In some cases, one of our studies actually is looking at an AR target agent along with it, and then spot welding the metastatic sites. I mean, that's the kitchen sink. That's everything we have trying to say, if this is all it is, let's go at it full force. We have no idea if that makes any sense.
Yeah,
but there are good trials being designed, though.
Well,
that's the thing.
But I think what's important, what Mike says is, and I've seen this at our leading academic institutions, and I've seen this both in the United States and abroad. There is this movement towards, the pendulum has swung back to being more aggressive on treating oligometastatic disease. But your point is well taken. We don't have any level 1 evidence that that's of value at all, and we want to be really careful to recommend that we have to design good trials and get the evidence to find out what's the right population and what's the right multimodality therapy, or otherwise people, community-wide will just start saying, well, we'll start getting super aggressive again, and I don't think we want to do that.
Right. I think Neal, when you and I trained in the '80s, where the thought was it was only going to be one mode of therapy, and I think the concept of what we used to do, and obviously what Dr. Walsh wanted, what he advocated early on, was that if you had positive lymph nodes, you stopped, because the concept was the tumor had obviously spread outside the confines of the prostate, which made surgical cure, given the associated morbidities with radical prostatectomy, sort of unacceptable from a quality of life standpoint. I think, again, this interest, I think that probably, because if you were a high volume prostatectomy center, I think yes, there is associated incontinence and sexual dysfunction. However, there is always, to me, some value, especially in higher volume tumors, to get that out, because when they do recur, if you left the tumor in, the problem with locally advancing disease, bladder neck obstruction, bilateral ureteral obstruction, hematuria, those types of things is miserable, was miserable. But Mike, your point is well taken, is that this whole, and we can talk about this now, and how it relates to the CRPC space, these newer imaging techniques that are going to start coming on board.
It's the newer imaging, and it's Decipher RX, these things that sort of really say high risk, or you've got disease that we knew might be there, but we could never detect on our traditional scans, but so makes us think differently about how aggressive to be.